Oh, okay.
I know Shriner's on there.
Frontier.
Frontier's on there.
And where was start with that?
I don't know where those sites are. Everybody.
Good afternoon, everyone. We're going to get started. It's 12 o'clock, and we like to start on time because we have so many sites, satellite sites that are outside of here, and they're ready when that clock strikes 12, and we like to just honor everyone's time. So, my name is Angela Smith, and along with Ken Akinaka and Valerie Jans, we are a committee of three that are overseeing this teleconference that we have here every month. What our positions are is to try to bring to you some of the best speakers that we can find in the community to share their expertise on different topics. And this month, we are very, very fortunate to have Josh Green, Senator Josh Green, MD, very accomplished man and distinguished. I'm honored to be able to present him today. Let me get my glasses out. While I'm doing that, I'd like to just say that if the restrooms are downstairs, this is a brown bag session, so if you have lunch, feel free to snack on your lunch. We have people still coming in. Up until the last minute, I was getting calls for either directions or information on whether or not it was too late to register. And of course, we have walk-in and registration at the door here at this site. At our other sites, where we have limited space, we can't always afford to do that. So without any further ado, I'm going to, for those of you who know Josh Green, you know that he is a very accomplished man. I was on his website recently, joshgreen.org, and I recommend you all go there and just check it out because there's so much information about the good work he's been doing in the community over the last several years. So here's a short bio of Senator Dr. Josh Green. He was educated at Swarthmore College and Penn State University, where he received his medical degree in 1997. And after finishing medical school, it says Josh traveled to South Africa, where he worked in missionary hospitals as a volunteer physician, treating the rural population overwhelmed by AIDS and malaria. Upon completion of his residency training in family medicine, Josh accepted a position in the National Health Corps to practice medicine in underserved areas of Hawaii. In 2009, he was named Hawaii Physician of the Year. And then he's worked now, I think he's currently still working, if I'm correct, at the emergency room as a physician on the Big Island of Hawaii. And he was elected to the State House of Representatives on November 2nd of 2004 and served 2 terms. Went on to spearhead the movement to provide affordable and accessible quality health care for all people of Hawaii. In 2008, Josh was elected to the Hawaii State Senate, where he now serves as chairman of the Health Committee and provides a leadership role statewide as Hawaii's voice for health care. And of course, we all know that recently on November 6th, Josh won by a landslide, second term as senator. So congratulations. Let's give him a hand. Thank you. He's married to Jamie Ushiroda. He married in 2006, and he's the proud father of two beautiful children, Malia and Sam. So we're very fortunate to have Senator Green with us here today, MD, and I'm excited and very eager to hear all that he has to say about our Affordable Health Care Act. We did have a flyer that went out to everyone with some information and bullet points on some of the points that will be discussed today. One is the future of primary care, health care as a right or choice, and will health care unite or divide America? So with that, I'd like to bring up and introduce to you Senator Josh Green, MD. Awesome. Hello.
Now I'm going to come back here and sit down. We've got an hour and a half together. Thank you so much for including me today. Huh? There we go. Then I will make a move. There we go. Incredible relief. I feel like I'm at home getting advice from my wife. Thank you, Val. If people can't see me, I'm not that good looking, so it works just fine, for sure. It's like I said, it's a real pleasure to be with you. I hope we'll have an extremely informal hour and a half, and I'm absolutely open to people interrupting, asking questions, riffing with me on concerns they have right throughout, because I was telling some of the gang beforehand, so often when we do these kind of talks and conferences, we have a whole raft of people, and everyone has to, get in their 6 minutes of ego, which is, okay. I'm one of the most egotistic people on the planet, so happily a part of that, but we often don't get a chance to really ask questions and get into it, so please don't be shy. So many things to say about the Affordable Care Act. First of all, I'd like to preface this by saying that March 23rd, 2010 was one of the biggest days from a health policy standpoint probably in the history of our country when the Affordable Care Act was passed. And that's a day that we really need to remember. We've come through the election. I'd say there's been some serious validation that we're going to be continuing with the Affordable Care Act under President Obama. I'm not a particularly partisan guy, but I was relieved to see that we wouldn't have to retrace our steps, because so much has been done and so much time, professional expertise, so many graduate students have studied this, so many nurses have planned their careers based on this, so many young doctors have prepared, health policy people around the states have gotten their budgets ready for these things. So it really would have been very, very difficult for us as a country to go back. So I was happy about that. I also think in terms of what this means to America when I think about the Affordable Care Act. I think that one of the things we've been lacking in our country for a very long time now is a common purpose. And I'm not trying to get all teary-eyed about this kind of thing, but at some point or other, our country is going to have to decide to get on the same page. Republicans and Democrats and Libertarians and Tea Party guys and uninsured and insured and corporate folks and people that are struggling. We all are going to have a few ideas that we really believe in together. It speaks to the question of whether or not healthcare is a right or a privilege, but I can tell you this. As a country, there has to there has to be a premise that we agree on. America is a terrific country. It's extraordinary in so many ways. But without a common purpose, we fight, we have uncertainty, we're not nearly as strong as we could be. And it's been at least my contention as a physician, as someone who spent all of my working time in healthcare, that health policy is that best place to find a common purpose for our country. And I'm very hopeful now that as we see things unfold, and we're going to talk about the details today, as we see things unfold surrounding the Affordable Care Act, surrounding the ability to get care for everyone in our country, that is the common purpose that tends to unite us rather than drive us apart. And I think it's very possible because I'll tell you, it's such an extraordinarily broad subject. And as everyone knows, the Affordable Care Act itself, Obamacare, I'm happy to call it either, is so large that really there's no one in the healthcare industry or in the country that doesn't touch it some way or other every day. And so it is an opportunity for us to find a common purpose as a country. And without dwelling on this too much, because I really want to dig into some of the details for the group today, to have healthcare for everyone, I think, is to provide psychological security for a country. I think it is the kind of foundational element that a country can have after its public safety, which is always the purview of the presidency and what's most important to most people in a country. But to have that psychological certainty that you can get health care if your child's got asthma, if you have chronic kidney disease, if you've got COPD and you don't know whether or not you're going to be able to access your inhalers and oxygen, that's no way to live as a country. It's not at all sustainable economically. We know that. We've seen how difficult it is to have a healthcare system we can't pay for. But more importantly, it's no way to live. It's no way to have neighbors living. It's no way to have family members living. It's just no way to run a country. So the most important thing from my perspective, and this is not me speaking politically, but speaking just really emotionally, being a doc, is that providing that foundation in our country, healthcare for everyone, and we'll get it. We'll get closer to right every year if we continue to work hard on this. Nothing's perfect. But as we get closer to doing the system right, our country will be able to breathe a sigh of relief. I really believe this. And to breathe that sigh of relief and then move on to some of the other big issues that exist. As a team, you can all say we looked at our neighbors, we looked at our companies and our workers, we looked at our healthcare system, and we said we're all going to be in this together. For whatever reason, whether it was economics or just people trying to do the right thing, I think it's going to make us a much better country. And I hope people will see that now that we're past a lot of the infighting, past all the elections, we can hopefully turn our attention to the details and getting this thing right. I think I'd be remiss if I didn't tell you a little bit of a election story, because we've just come through the elections. Because elections are what decide some of these things. But I'll tell you, it is a fickle world out there. And just to give people an idea of kind of how on the edge we could have been, whether you wanted the Affordable Care Act or not, I mean, some of these political periods decide which direction we're going to go. I thought I'd tell you kind of a story from the trenches. So I was out walking in my scrubs, which is probably psychological warfare against my own constituents back home. And in my scrubs and my shorts, and I'm walking with my flyer. It's got a picture of me about 8 years younger than I actually am. So it gives people the wrong idea right off the bat. And because I'm cheap, I had the same picture on both sides of the flyer. And I ran into a really nice older lady. She's about 72 years old. And I have all these things. I'm hoping people are going to read my flyer. It says, fighting for health care, all that stuff that Angela said, most of which is courtesy of you guys helping me do it 24/7 these last many years. But I'm hoping people are going to read all those things so we can get an idea. Yeah, I'm fighting. We want to get coverage for children, and we want to do the Hospital Sustainability Act, all these things that fit into the Affordable Care Act. I spend all my time. But really, people only look at that picture. So she looks at the picture. She takes it out of my hand. I'm giving it to her anyway. It says, "You look just like him. I like this young man. I think I'm going to support him." And then she flips it over. I'm trying to get a vote because I care about. I want to run the committee and do these things, right? She flips it over and she says, "He looks just like the other guy. I'm going to support this young team for my senator. I thanked her. I said, thank you, Aunt. I gave her a hug. I said, please tell your friends about these nice young men that are in our community. But the reason to have these elections, I think, is that, because I'm looking at my calendar and I'm thinking, on the 16th I get to be here with Ken, and I get to talk about what it will mean to us as a country. And I think about what it might mean to sit in a committee again and work out the details of the health information exchange or the actual connector itself. A lot of the devil's in the details, and that's what elections are about. So anyway, I'm very happy that they supported that much younger looking guy on the pamphlets, but it is a strange process. We talked a little bit about, Angela just touched on briefly what informed me in getting into health policy, and I just, not to dwell on it, but my experience in healthcare I think is a little bit different than most physicians' experiences. First of all, I just finished a shift last night, and I'm going to talk about one of the cases because it's very informative about the challenges we face in the Affordable Care Act, midnight last night at the little boy. But it's not bad. He wasn't that sick, but it's important. But when I went through medical school, I went to a med school at Penn State, which was very good. They focus on primary care, and I think I'm going to come back to that theme several times because I really think that's what the Affordable Care Act is about. As we get into the details, we'll tease out some of what we're spending with the Affordable Care Act, but the broader view of the Affordable Care Act, if you really want to know what the whole Affordable Care Act is a massive approach to move our health care away from an end game, expensive, probably not as intelligent way to provide health care to a much better primary care based, compassionate, broader approach to health care. And so when I went to med school at Hershey, which is where the med school is there, lived next to the Reese's Peanut Butter Cup plant for 2 years. It was not helpful for my weight, I can tell you. They focused on primary care already, and they encouraged us to go and have other experiences, and some of the good medical schools do that. It was quite a good medical school, actually. They encouraged me to go from that primary care setting to Swaziland, where I volunteered in first the Nazarene Hospital and the Catholic Hospital, both of which were ironic because I'm an agnostic Jew married to a Mormon. So, that was all very unfamiliar to me, but the prospect of seeing patients in a very, I'll use the word third world country, but a very developing country where no one had insurance, no one had access to basic care, as opposed to the residency. It was just, the medical school experience, that I was just finishing, where virtually everyone had coverage at a tertiary care setting in Pennsylvania. It was a profound difference, and I can tell you that really shaped how I think about healthcare greatly. People would come in the mornings, you'd wake up, and you would run over to the clinic about 7, just at dawn. It wasn't about what time it was or what time. No one had scheduled appointments, and a line would be stretching out for a quarter of a mile. Incredible lines. People, everyone would come for care all at the same time. Their family members, 6, 8 people would all come, and you would take care of everyone. There was not one visit. You didn't worry about billing, ever. It was pretty much supported by philanthropic organizations, and there was no chart. It was a 3x5 card that the family carried, and the doctor would do whatever we could do with our stethoscope or the medications that were brought from the United States or that we were able to scrounge together, or the surgical procedures that we thought were necessary. And then you wrote a little note on the card, and you handed it back to them, and they went and either got the medicines or got admitted to the hospital with that one little line, or they didn't. They went home. There was no prescription. There was no nothing. And there was no medical malpractice question. There was no technology. There was only what went on between the physician and his or her patient for that brief period of time. And we provided an incredible amount of care. I was young. I had a lot to learn, but the things that we were able to do for people, when I reflect on that, were quite extraordinary. We would see, one day we saw over 240 patients that had malaria. That was, Angela mentioned that. These were quick visits, but when a kid comes in with fever in Swaziland, or South Africa, which is where Swaziland is, a high fever, 103, 104, with a little jaundice, you know they have malaria, and you just have to find out how bad, and you do the blood test, and that's the visit. And then you start medicine, or you decide that they're going to die anyway, and move to the next child. So it's a very, very different experience, and I think it informs us about the differences in the cultures of healthcare around the world. What that brings me to say is that when I came back to do residency, and I experienced large charts, and every patient had an hour or 2 hour workup in the emergency department with an incredible number of tests and a $4,000 bill, which if they were uninsured, they were in deep trouble. If they were insured, they still paid 20%, and they were, I don't know if you're like me, 20% of $4,000 is still $800, and it hurts. They fixed my hernia here the other day terrifically, but I still pay $1,100, for my copay, and it's not lost on me, is what I'm saying. Whereas we are taking care of people for, I don't know, 30, 40 cents, in relative dollars, and providing very different care, but in some cases life-sustaining care. So that made a big difference to me, and it's kind of why I went towards the National Health Corps afterwards. I was interested in seeing what that side of medicine, that experience of medicine was like, and that's what I did in KAU for 4 years. And again, really extraordinary experience taking care of people. I would say it was somewhere in between an experience in a developing country and what one might get in Honolulu when you can come to Queens and have really exceptional emergency room physicians and trauma surgeons and neurosurgeons and internists and tests. So we didn't have a lab in KAU. We had x-ray 12 miles away. We had no pharmacy in Nalehu, and people didn't have cars a lot of the time. They walked in from the community, or they certainly didn't have resources a lot of the time. More than half the people in that part of the state are on Medicaid and have significant troubles paying for their care. And so, I had already some familiarity with people having difficulty getting access to health care. And so that's why I'm so passionate about us getting this right and getting it right for everybody in the country, because I think we can, and it's one of the many reasons I'm doing this and here with you today. So I'm going to lay out a case, and I want you to think about it a little bit before we start talking about the specifics of the Affordable Care Act. So a kid came in to see me last night with his tutu, and it was midnight or so, like I mentioned. I'd seen a couple patients at one of our rural hospitals on Big Island. I flew in this morning, and chief complaint was shredded weed up his nose, okay, which is not the biggest health problem that exists. And so, beautiful little boy, very upset about this shredded weed issue, and I don't even know what he was doing eating shredded weed at midnight or 11 p.m., but he came in and he had a pretty good wad of shredded weed up his left nostril. And he was in the ER for this, right? And I'm not trying to be critical, but all we really had to do was hold the other nostril and tickle him, and he snotted that shredded weed out, and he was good to go. And I wrote up my 5 pages of charts, and I'm sure they're going to get billed through the hospital, and it's going to be a $400 visit for this snot ball of shredded wheat. And when you think about the Affordable Care Act and all of the important parts that go into it, we also have to, what I'm saying is we have to think about what we as individuals are going to use our hospitals for and use our physicians for, and ask our nurse practitioners and our nurses to participate in, and what sacrifices we're all going to make this system work. I think that's going to be very important, because we're going to constantly be reassessing this major transformation of the healthcare system via the Affordable Care Act, and wondering, can we find the monies to provide health care for people with chronic and persistent mental illness? Can we find resources for people that have drug addiction, where we usually don't pay very well or provide much good service for drug addiction? Can we find the resources to hire the surgeons that we do need for big-time problems? It's really a big question. And so when I see a patient that just needs to be tickled and have their nostril held like that, I say to myself, my God, number one, I'm upset because I'm up out of bed again, right? As that's the stubborn doctor in me. But I also say to myself, we really are going to have to make some hard decisions. I'm not talking about death panels like Sarah Palin. The only thing I know about Sarah Palin and have in common with her is we have the same darn birthday, which my friends all torture me about every year. I also share the same birthday with Jeb Bush, so I'm really conflicted now. But, I think we have to be fair to the system and the process and really ask ourselves, can we afford these things? How can we convince each other to communicate with our organizations, with our groups? It's not just about stopping smoking, which is probably the most important thing we can do, and getting control of diabetes and obesity, because obviously you read in the paper today, 117% increase in diabetes in the last 15 years in Hawaii, which is not even the worst in the country. A lot of states were much worse, Alabama, Mississippi, I think. So we're going to have to do some smart things as a people, which again speaks to this idea of a common purpose to make it happen, but it is possible. We can have more health literacy. We can make good decisions about our hospitals, and we can keep in mind these good decisions pay for more psychologists. They pay for more home care visits. They pay for more admissions for people who are elderly when they really need them. They pay for more bypass surgeries when someone, God forbid, has a heart attack in their 40s or 50s. So let's keep that in mind. In Hawaii, we're in a unique spot. We have only 9% uninsured or so, which means that in some ways we are a little bit insulated from the larger impacts of the Affordable Care Act, but it still affects us in many ways profoundly. I see David, who's worked on these problems for years, and I think he might weigh in on that later too, but it's like it's a tenth of our population that for some reason haven't found their way into health insurance, and that's what a lot of this bill is going to do for us. We're hopeful. That's 120,000 people, more or less, and to give people perspective, and this is one of the big questions, what do you do when you add 10% of your population to the actual covered population? And you have to come up with more providers, whether it's doctors or nurse practitioners or PAs. That's something that we really do have to focus on. Again, for perspective, if it's 120,000 people, and that's a great oversimplification, because now we're talking about people getting more services and trying to do it right, but a physician should tend, if they're a primary care doc, should tend to take care of about 2,500 to 3,000 people in their panel. When I was in the clinic, because I was the only one down there, I had 8,000 patients, but most people didn't come for years until they were very sick. So it varies a lot, but that would mean we need about 50 primary care physicians right away, and we only have one medical school, and we don't routinely have an easy time recruiting from other states. So it's another thing that's important for us to focus on and be mindful of when we go for solutions. Okay, so let's get to the Affordable Care Act. The Affordable Care Act, I'll reiterate the philosophy. The philosophy, as you all know, is basically get everybody covered. Get everyone covered. This might not have been everyone's approach. Some people wanted single payer. Other people wanted to model a totally private system where unfettered competition made it very inexpensive to get health insurance. I never bought that. That was not my belief. I agree. But what we got is this. So this is what we'll talk about today, which is to get, at least at this stage of healthcare reform, most people into the insurance coverage. And if we do that, it will have certain effects, and we can debate these effects for sure. But I have a feeling, I have a theory about what really is going on behind the Affordable Care Act, which I'm going to share. But the premise is to get 35 million additional people covered, and get them covered fairly well for primary care services. Move a lot of the resources that you've seen in that 1,000-page bill, a lot of resources into primary health care, whether it's community health centers. There's $11 billion now being spent additionally on the community health center system. I jotted down a couple details. Right now, 1 in 17 people is taken care of at a community health center or some clinic of the sort, like the one I worked in. And we have about 10,000 physicians, 6,000 nurse practitioners, and 11,000 nurses in that system. But the Affordable Care Act, part of the bill, probably on page 655, somewhere deep in that bill, was the intent to build over 120 new community health centers nationwide and get people primary care so that they could get care for things like urinary tract infections and early depression before it became severe persistent depression, and they had problems with drug addiction as well, or other comorbidities. And to get people care for their bronchitis before they had scarring of their lung tissue and had chronic lung disease and ended up in the hospital all the time. So the idea is to get more monies into primary care, and I mentioned that example, that $11 billion example out of a multi-trillion-dollar bill, really, over 10 years, because that's the premise, really, to get all of that additional care to these people. Now, how do you do that? Because if it was easy, it would have happened in the last 30, 40 years, right? So it's not been easy. So it's really been a very staged process. We mentioned earlier that it all started in March of 2010, and here we are about 2.5 years later, and we've seen some implementation of it. We saw the bill pass, and we saw free preventive care in 2010. We saw small business get tax cuts to cover some people. We saw the exclusion on pre-existing conditions for children, and we saw that you could not keep kids off of people's insurance, families' insurance, if they were under age 26. That stuff is easy those are the easy things, right? Which is why, for political expediency, they did the easy stuff first. And we're building up to a climax here today because all the hard stuff comes in 2014. And so we're kind of here we're at the cusp of it. In 2011, they closed the donut hole. Everyone's familiar with the donut hole on Medicare, probably. And that was after you paid $1,000 or $2,000, there was a large amount of money that anyone who's on Medicare would have to pay before their pharmaceuticals be covered again. Very difficult for people on a fixed income to pay that, and that's why it was so contentious, and that's also, I think, why they went to that in 2011. These are just kind of highlights. But also, they offered the free preventive care for seniors. Some people describe that very negatively, as though we were priming seniors to have death panels and all this such nonsense. But it's not at all that. It's, once again, if seniors didn't have good oral health care, they had malnutrition. If they had malnutrition, they ended up in the hospital chronically. And if you end up in the hospital and you're a senior, it's $5,000 a day, one day after another. And then there's not a long-term care facility bed available, and you get stuck in the hospital, and Queens gets no reimbursement, and they start losing money. And they end up having $50, $70, $100 million of red ink, and they can't sustain themselves. It's why HMC West closed, because it was very difficult for HMC West to get adequate reimbursement from the federal government for Medicaid and Medicare. And there weren't enough long-term care beds to help them with some of their challenges. So what happened here, far away from D.C., we actually lost a hospital temporarily. Very real impact that I believe could have been averted had we passed this bill, under Bush or Clinton or whomever. So it's something to think about anyway. So we move to 2012, the year that we're wrapping right now. And this is where it starts getting a little bit more technocratic in some ways. What I've seen so far in 2012, these are more of the trial balloons of what's going to actually help some of the economics of the healthcare system. Again, I think we're going to have a chance to speak more philosophically later today about what's really good for the people of the country and what might have been a better approach, but there has to be some savings, because in the United States we spend about 18% of our GDP on healthcare, right? Does anyone know what they spend in China on healthcare? Anyone have a guess? Lower. 2.5%. Not guess 10. I would have guessed 10. I was shocked to find it was just 2.5%. Now they're trying to actually, this was going to sound crazy, they're trying to increase their healthcare spend because they have a lot of chronic disease now. They have a lot of problems with environmental health issues in the countryside. How about India? 1.5% of their GDP. And it's a basic utter disaster in India as far as healthcare goes. I mean, nobody that doesn't have money can get healthcare, period, unless their entire clan comes and spends all of their resources to get Western healthcare. They won't get any. So India is actually seeking consultants right now. So if any of you are a consultant and speak any Hindi dialect, you should go there right away, because they're looking for a real change in their healthcare system to spend more money on healthcare and to develop more hospital systems that can somehow approach what even the United States had, but maybe more circa 60s or 70s, with a simple healthcare system that can get at least basic healthcare to people. So India and China, you can see, are very different than us, and we're going the other direction. We're trying to figure out ways to flatten the cost of healthcare, and I don't know if it's possible. We're going to see. We're going to really learn some lessons. The Affordable Care Act is probably going to be most important because it's going to teach us the real lessons about healthcare in our country. So, accountable care organizations. That's a big piece of 2012. What are accountable care organizations? Accountable care organizations are, we could speak for a day about this, but better to speak for a minute, I would say, about it. And the minute version on accountable care organizations is you have doctors partnering either with hospitals or with themselves. They take responsibility for, in this case, we speak about Medicare, but it could be for all different populations, private, Medicaid, Medicare. They agree to basically provide all of the care for that cohort of people, and if there's any savings year to year, then the savings themselves are shared back with the providers. And the idea is to reinvest in care coordinators, to do a much better job on prevention, and to get people the services that maybe they want rather than the services that they get prescribed or tested for or seen in the ER for and what have you. So that's what the premise of an accountable care organization is, and there have been a lot of grants from the federal government to do these things. Some of them are working, about half of them are showing savings and half of them are not showing savings. But we're going to know in the next year or two whether this approach, which in many people's minds just approaches what managed care was before, which didn't necessarily work, but it is something that's been big in 2012, and I think you're going to still see more of that. You might see a lot of that in partnership with hospitals. Keep in mind that about 2 out of every 3 healthcare dollars are spent in the hospital in the country. About 1 out of every 3 is somewhere in the outpatient setting. Probably should be flipped. We probably should be spending 2 out of $3 on prevention and immunizations and making sure people don't get hepatitis and making sure children get, their all of their immunizations, if at all possible. Make sure that there's fluoride available for people. In Hawaii, I know we got controversy on that issue, but it's crazy. We should do it, for God's sake. We can definitely disagree. Just one person's opinion. Definitely. But there's so many things in general in prevention. I don't mean to offend. I think that in prevention in general, especially the things that we would agree to, because there's so much to do. Tobacco. Giving people education on tobacco prevention. Very basic stuff, right? So these are the things that we should be spending our money on instead of repeat cardiac tests when somebody already didn't want to go for another cardiac procedure. So I think that's what the goal is with accountable care organizations for people. Then there's electronic medical records. I think many of you have probably suffered that discussion at your facilities. Really, really controversial as well. A lot of money is being spent on EMR incentives, and I'm going to say this out loud, I'm not a firm believer that that's our solution. I can tell you one of the reasons we should do something organized as far as health records go, and that's because we shouldn't be wasting money on extra tests and we shouldn't be making large medical errors. I'm not positive it has to be a complicated electronic medical health record system to do that, but we do have to be able to track and have a better idea about population health, which is why it's been so frustrating to see governments all across the country decrease their budgets for public health services over the years. Those services were very important because it helped us to know where we should spend our monies, where we really have problems. And the current approach in 2012 to put all these incentives into electronic health records, my feeling is, again, just one person's opinion, is to throw a lasso around all the information in the country so that after this experiment with the Affordable Care Act, we can see maybe better how much money did we spend, where did we spend it, where do we still really have big health problems. In that way, I think it is good to know. But I'm not necessarily certain that we had to do a piecemeal electronic health record system. Frankly, if we were going to do it, it would have probably been better to do a very centralized single system that was maybe a little more basic, but literally give it away to everybody. Look at the essential health problems. Pick them. For example, diabetes. 10% of our monies are spent on diabetes now. 10%, which in the United States, that's $300 billion a year. It approaches our defense budget. You subtract Afghanistan, which are not going to be in Afghanistan much longer. So $300 billion in diabetes care alone. We could have just tracked diabetes and hypertension and we would have been close to the mark. But instead we have, I don't know how many of you have looked at your systems lately, but it is complicated and it slows people down and people are actually less productive in their first year with electronic medical records. So it's a big challenge. Maybe it will pay dividends later. It's not for me to judge. I'm just saying that that's a big part of the 2012 part of the Affordable Care Act. Also in 2012, we had a big moment, of course, and that was the Supreme Court. So Supreme Court ruled 5-4, as you're all very aware, that the Affordable Care Act would stand. And everyone has a different opinion as to why 5 people ruled for it. In some cases, some of the more conservative justices ruled for it. One of the more liberal, Kennedy, I guess he's on the fence sometimes, justices ruled against. But, you know, again, difficult to know what's in people's minds, but it did survive. And then in the wake of the election, it is surviving. It's going forward. So that was, I think, the most significant moment for the Affordable Care Act. Had we had it shot down, we would have gone a totally new direction, and we would have pretty much put everything into the scrap heap that we've done the last couple of years, which at least would have been disappointing to me. I don't know about you. So now that brings us up to present, right? This is November 16th, 2012, and all of the new initiatives are beginning to roll out nationally. We're past the elections. Everyone's going to have to work on things together one way or another. So what's going to come in 2013 and 2014? Well, 2013 is kind of now getting serious. We tinkered around with the account care organizations, and we closed the donut hole, and we provided some preventive care, and so we started to do those things, started to build some more health centers. But now the big guns come out. In 2013, the federal government will begin to tell hospitals, hey, if your patients end up back in the hospital again, we're not reimbursing for it. Some of those rules are still, up in the air a little bit, but they're hardening quite quickly. I'm not an expert in this area, but I can tell you that I've had discussions with Art here and with Chuck, and they're very concerned. The challenge to keep people out of the hospital is not a simple one, and people all behave very differently. Some people rely on the hospital. Of course, we know that there should not be a situation where someone's going to the hospital 100 times a year. We have those people. Dr. Ireland will tell you he's got a patient that runs the medic. He's the medic guru here for us in the state, Jim Ireland, and he's got one patient that's gone, I think, 150 times by ambulance to the hospital in a year. I mean, they have alcohol problems, but it's a health problem, and it's just can't do that. I mean, that is an expensive cab to nowhere, basically. And so some of these things, of course, have to be kind of handled, which is good. So I'm glad the government's stepping in there. But, when to tell you the truth, people are going to have relapses over their heart failure. I see people every single year come in right after Thanksgiving and right after Christmas dinner, because I'm always on call because I'm Jewish, right? So they put me on call for Christmas. And so I get Christmas. I'm free for Hanukkah if you guys want to party, but I am pretty much tied up on Easter and Christmas. And so those are the big salty meals, and people get readmitted. And what are you going to do? Tell people they can't have ham in Hawaii or Kahlua pork? That's just not happening, right? So there are going to be readmissions. Now, are you going to tell a whole hospital system that they can't take into account a cultural phenomenon and therefore not reimburse them and penalize them? So one size doesn't fit all, and I'm concerned about that. I'm sorry?
I just wondered, are you...
Yes. Yes.
And we're beginning to get more referrals for our elderly. Not that they're their short, but are there other resources that are available?
Yeah. So I'll restate the question because in case we don't have mics. So the question is a very good one. It's so if you're on the Big Island, for instance, which would also apply to Kauai or Molokai even more seriously, probably what resources does one have to help with case management and readmission? It's very few and far between, I'll tell you. The resources are absolutely limited. My experience notwithstanding, I work only weekends because the rest of the time I'm here in the Senate, so no one is available on the weekends, ever. So I often have to admit patients for observations in the hospital, try to work up home care for Monday morning, even though I probably would like to send them home Sunday morning. So many things are just totally not available, and that's just an extreme version of the week, where the better facilities do have more resources, but even North Hawaii Community Hospital is having challenges economically, and they've historically had more money. One of the things we passed at the legislature last year was we called the Hospital Sustainability Act, and what it did was it had the hospitals kind of tax themselves, and money went into a bank account, and then they matched federal dollars, and it came back to them. So they recouped an extra $50 million for the system. It was meant to do exactly what you say, which is to hire case managers, to hire home nurses, to hire specialists on education for like medication reconciliation, because almost none of the hospitals have much more than a decent checklist and a discharge plan. And then a lot of the people don't have primary care physicians. So they end up seeking their primary care in the emergency department, which is just not feasible. I mean, it's not sustainable. It doesn't work. You don't have the records unless you come to the same ER, and then I know you if you come on weekends again. I have this weekend crowd that I see real frequently, you know. But they tend to be drug addicts and alcoholics, and we're just trying to help them get through the tough part of their life. It's not so many people with their kidney disease. Although I do have, for instance, another example is, again, speaks to your question, I have a couple people that end up in the ER with heart failure every Sunday night. Why? Because they are on dialysis, and the dialysis only goes Monday, Wednesday, Friday, and so they have that extra day. And, you know, what are you going to do? It's an extra 24 hours of fluids that are building up. I mean, there are phenomena in the healthcare system which are very hard to fathom. And we need those case managers, and we need more outpatient care, and we need these solutions where people add extra hours. All of those things are meant, if President Obama were sitting here with Sebelius, I think they would say, yeah, that's what's in the bill. That's what some of this stuff is, the accountable care organizations and the patient-centered medical home, what have you. It's meant to hire those supportive teams. And if the system works right, and in some ways, some things are working right. For instance, I can't even believe I'm going to do this, but I'm going to say something very, very positive about HMSA. We've often thought, but they've done a pretty darn good job setting up the patient-centered medical home project for primary care physicians. In fact, I really commend Mike Gold and Hilton Rathel and those guys. They thought it through very carefully, and they're putting a lot more money into primary care for primary care physicians, and that might not be a great comfort, say, to those who run hospitals, but the physicians that I work with, like when I'm working in the Hawaii IPA, where I spend some time, my primary care physicians are getting an average of $75,000. That's the mean, okay? $75,000 per year based on their medical homework. And they're able to, medical homework, not homework. And their home care nurses now are hireable. They're bringing students in to spend much more time explaining the basics of people's health problems and how they can keep themselves out of the hospital and so on. So it really helps the hospitals theoretically, because if the primary care people do things right, then you won't have those readmissions, which they can't get paid for or soon won't get paid for at the hospital level. And that's another example of what the Affordable Care Act is meant to be. And so if we nationally do good things to get more care into primary care, I think we're going to really see a much better healthcare system. So let's talk a little bit more about the specifics of 2013. This hospital readmission reform is significant, but another thing that's meant to happen now is that you've probably read that Medicaid reimbursements are going to improve in 2013 and 14. They're going to equalize Medicare and Medicaid reimbursements for a year or 2 years, and then we'll see what comes going forward. It's something that I can tell you Susie Chun Oakland and me to a lesser extent. She's much older than me and has been there much longer. You please do. Susie is a gem, of course, and we've wanted for years Medicaid to equal Medicare because we never wanted people to be discriminated against by providers why should anyone ever look askance at a person that's poor and not give them the first slot in their schedule if they have the most medical need in the schedule? So not many providers do that, but everyone was so overwhelmed because of the shortage of healthcare providers in our state that a lot of times it was more difficult to find a provider if you didn't have private insurance, if you were on Medicaid. And 275,000 people in our state have Medicaid coverage. Over half, I think I mentioned this earlier, on Big Island. Over half of the people that live on Big Island have Quest. And those physicians, a lot of times, were leaving Big Island because they couldn't pay their bills. They couldn't pay their loans back. It wasn't because they were greedy, believe me. I had a bunch of physician friends over there that were making $55,000 or less a year, and they still had to pay medical school loans, and they still had to pay rent, and they had a spouse who always worked, and it was just too challenging. And they had to pay for private school maybe if they didn't like the public school. It sometimes happened. So these challenges are there, and by improving the reimbursements on Medicaid, though it will be expensive for the country and for states, because states have to pay a significant share of Medicaid, it will simplify the system. Now, had I been writing the whole healthcare reform bill, I'll tell you frankly, I would have erred towards single payer. Just my general feeling, you're an anti-fluoride, pro-single payer. You're like my mom, okay? I like that. So what I say about single payer is that it would have had to be a uniquely American version. I mean, we know people have different expectations than friends of ours have in Britain or Sweden or Norway or China or Canada. Sorry, yes, our Canadian friends. So we have different expectations, but I did think that there was a significant possibility for us to go to a modified single-payer system where people could at least get primary care exclusive coverage. And I think that would have been an approach that would have stabilized the care base of primary caregivers. It's, of course, an incredibly large thing to flesh out, but it is one thing that probably could have been done. But this is not what we're here to talk about today. We're here to talk about what's really happening. And so I'll go back to my point, which is by increasing Medicaid reimbursements, the hope is that it'll be easier on primary care doctors to provide the care at their facilities to keep people out of the hospital. Okay, so we're pretty clear on what's happened so far, right? Up to 2013, more people are getting coverage. We are spending more money on primary care. The government's clamping down a little bit now on what we have to be responsible for, not doing readmissions, making sure people reconcile their medications, maybe going for EMR incentives, try these other programs with accountable care organizations to save money. But now, how are we going to pay for this, and what are we really going to do? And that's where we're going to come to in a second for 2014. Val? I'm likely to not have all of the accurate details for you, and they do change pretty frequently, but one of the incarnations, and someone else in this room might be more expert at this than me, one of the rules as they're being written, and that's the way these bills work. A lot of things are spelled out in the legislation, but a great deal more is spelled out through committee work afterwards in small groups that get appointed by the Department of Health and Human Services. So it's basically for a month you can't be readmitted for certainly for the same problems. But there has been a great fight between doctors and the government, and I think it's a smart fight, because imagine, however, if it was anything, and this has to be resolved. For instance, you have someone who has heart failure. A 70-year-old gentleman's got heart failure. It's pretty common to have a little heart failure. They go into the hospital. But they also then drop they're cleaning up their garage, and they drop, a tire iron on their foot and have a laceration and end up having to have a surgical procedure. There's no reason to penalize a hospital for someone who's foolish enough to drop a tire iron on their foot in surgery, but who happened to have been in the hospital 2 or 3 weeks before for heart failure. And so initially it was for anything. I have been told that they're trying to reconcile that. I wish I could give you more specifics. And I will say this, go to the Health and Human Services website. They do update it pretty well, and I would say I found that Their descriptions of their rules are pretty readable and they're pretty accessible. And they actually do take input, surprisingly. If you happen to go to a conference or they ask for input, it's not just hospital executives and leaders of physician organizations doing it, like at the AMA or the Family Practice Association. It's really anybody. And there also tends to be a pretty big uproar when a rule is really, really draconian, like it would be if it was for any health issue.
Yeah, so a lot of COPD cases.
Exactly. So, yeah. So I guess I should say again what Val was saying was, and she's a COPD advocate, of course. You could have COPD and heart disease and depression and diabetes, and so if you have one problem, they're admitted for your COPD. Should you be held accountable if they also don't take care of the other problems? But there are going to be restrictions. Let's be honest. We know that the expectation is going to be if you go into the hospital and you're spending time there and you're seeing a physician staff and a nursing staff, they want us to do a more holistic approach to the patient. They want us to make sure people are on the right medications, that they are not neglecting other problems, so that they do just come back 3 days later for, even if it's something different but with something preventable. The spirit of the law is that they don't want people getting readmitted, period, in short periods of time because they need to shrink down that cost. Okay, so on healthcare.gov, it was just mentioned that you can do a search of the rules and regulations. And I'll be honest, I'm not great with details on some of these things because I tend to wait and let them see how they're going to breathe before they bring the rules in. I've been burned too many times where they give one rule and then it changes quickly and it changes again. I think it's better to give input until the implementation dates come. And usually common sense will prevail on some level for some of these rules. But that's why people are very afraid, because these are big changes to the healthcare system. Okay, so now we've talked about reimbursements, the readmission reform, and all the other things. So what happens in 2014? 2014, the mandate lands, okay? And the individual mandate is really the cornerstone of this bill. The idea, again, is that you need to capture everybody. You can't just have people who are generally healthy, don't want to pay for insurance outside of the system, because you end up skewing the system towards just the more expensive individuals and health insurance becomes too unaffordable. That's the premise. So the individual mandate is basically a requirement that everyone in our country is insured. And here's how it works. If you have insurance, you are able to keep your insurance. But meanwhile, states across the country, and it will be almost all states, and if the state doesn't do it, the federal government will apply it to your state, will apply an exchange. And you've seen a lot of that action here because Hawaii, being a pretty blue state, frankly, we were quick to decide to pass a bill to create the health insurance exchange. So the health insurance exchange is really meant to be like a portal where anybody can go and compare plans that have at least a standard that is good enough. They picked HMSA's PPO standard, I believe, and that way that's what you get. And you can bid across the different choices, and that puts you in a place where you can't, no one will be able to vulture down on you and take advantage if you're just you have a family business of 4 people or 6 people, and somebody had a pre-existing condition, now took care of that. That was one big problem, or somebody else was elderly and they treated them unfairly, or someone was a woman, and that was the ultimate discrimination, where women were being discriminated against and having much higher premiums. Why? Because in childbearing years, at least this was probably the reason. Yes? The comment was being discriminated against over 60. And so all of those, there's a major attempt to close those discriminatory policies down and to have the health insurance exchanges available and really practical for people to use. So those go into play, and 80% of the people on health insurance exchanges will, they believe, be subsidized in some way, because the health insurance exchange will, of course, be not for people really who are on Medicaid Medicaid programs will still exist, but for people anywhere in the poverty zone, from 100% of federal poverty up to 400%, if they aren't qualifying for a Medicaid program in their state, which the feds are going to be providing extra resources for, they'll get a tax credit, so it won't be a demand that you pay it, even though you're still pretty poor as a family of 4 or 6 and have no chance, because there are penalties associated with it. I think that they'll probably visit this again in the legislatures. I would not be surprised at all, because it was a tough, even for me, it was a tough pill to swallow to imagine people being fined if they refused to buy something. It's a kind of a fundamental question, which a lot of Americans are going to tend to have a hemorrhoid over, right? Which will be covered though under Obamacare. So, the penalties are like $95 for an individual adult, or up to 1% of their salary, whichever is greater, in the first year. I drew a little chart for myself. For 2015, $315 per adult, or 2% of their earnings, and then it goes up to $695 per adult, or 5% of their earnings, whichever is greater. So, just to give you an example, let's say you're outside of that gap, which is up to $88,000 for a family of 4. That's the threshold, the highest threshold of 400% of federal poverty. So let's say you made $100,000 for the math, to be easy for the family, and you just did not want to go for health insurance, which is going to cost you. We can discuss what that would cost you, right? But if you refuse to pay into the system and it was $100,000, you would pay a $1,000 penalty that first year. And presumably, that money for the family would then go toward additional purchasing pools, or humanitarian care at clinics, or just compensating hospitals for the care they delivered for someone who showed up and was uninsured. You might still get bills. Actually, not clear in my mind exactly what will happen, but it goes up and up. Let's say you're a family that makes $200,000 and you just insist on not participating in a national health program. By the third year, you would pay, 2.5% of that $200,000, which would be a $5,000 penalty. And that would still be significantly, as you know, less than what it's going to cost for that family of 4 in a healthcare program. So are questions that still remain. Healthcare costs are still going up everywhere. They're going up less in Hawaii anyway, but some places they've been trying to get ahead of this curve and charge us a little bit more. So you can see that that's going to be a very big kind of change in philosophy. And at the same time that we're putting together the health insurance exchanges and having people basically apply the individual mandate, I want to say be punished with an individual mandate, because it is meant to get everyone together on health care, we're also going to be expanding Medicaid, so that there are many individuals still across the country that just couldn't qualify for Medicaid because states didn't have enough resource. The federal government is generous in the first few years until these systems are put into place. But I'll be honest, this is the stuff that gives John McCain fits, right? Because he's conservative and he really didn't like the idea of expansion of social programs. Just him. I'm not being critical. I'm just saying that's what the conservative spectrum were worried about, or a man. And people on the liberal side of the spectrum, or Barack Obama, they were saying, no, this is a social program that is smart, that is worth doing, and we'll try to keep it somewhere down. Definite major philosophical conflict. There's no question. So, I'm going to talk just for a couple more minutes, and then I can really open up to questions, because I wanted to mention a couple of the things that are kind of the wild cards in my mind about the Healthcare Affordable Care Act. One is what will happen to physicians. So, if we do go to a system, because this money has to come from somewhere, and a lot of the savings, so to speak, coming out of Medicare. And in order to do that, those of you who run programs that rely on Medicare reimbursements, or hospitals that have had Medicare populations utilize them, which is a lot of facilities, right? Almost everyone, because the people we see are people over 65, for the most part. It's not just that little kid who put the weed up, the shredded wheat up his nose. I also last night had a kid, a grandpa who had chest pains, and he was on Medicare, and he had to treat as though he might have a heart attack. Thank God he did. But, those are the people we care for in our facilities. If the reimbursements don't cover costs adequately, we can run into the scenario that we suffered at HMC West, which was gradually a drift to insolvency and losing services. So we're going to have to be very mindful that make sure the reimbursements actually are adequate for our professional workforce. There's no way around it. It has to be addressed, should be addressed directly and sensibly, and you get what you pay for. If you don't pay for those services, you can get very good services from other providers, nurse practitioners and what have you, but they're not the same services, and so people have to be familiar with what they're getting and accept it. That's one thing. Two, we're already, today, we have 950,000 physicians in the country. So that number is 4 years old. But so about 950,000 to 1 million physicians. But the shortage is profound in a lot of places, especially rural areas. We in Hawaii, David and Kelly Withy worked hard on this project. We have about a 22% shortage was our initial report. It's kind of flatlined, doing some good things with the loan payment program and getting medical school to focus on primary care people, have people stay. But we're still short, and the population continues to become older and has more needs. So we, at a time where we're shrinking the amount of monies potentially into healthcare, we have to find a way to get more people to provide healthcare. And that's a fundamental problem. And I don't know that there's a good solution built into the Affordable Care Act yet. That's probably my largest concern. Right now, that's a very good point. Okay, and that's why we created the Hawaii Health Corps. We created that as a mechanism to bring these resources to us in Hawaii for loan repayment and what have you. The comment was that across the country there are resources being put into place to get more training, essentially for whether it's pharmacists or nurses or physicians. However, one has to remember that it takes a long time to train a provider of any sort, particularly a physician. It takes not just the 4 years of undergraduate, and it requires they be very attentive to their studies in order to get into medical school. Then 4 years of medical school and at least 3 years of residency, so it's a commitment of 10 years at least. So in order to get ahead of that wave, that tsunami, so to speak, it's going to be a big challenge. And no number of foreign medical grads is going to be a solution for us, and it's probably not the best solution anyway. I have good friends that are foreign medical grads, but that is not the solution. Right now we have 170 medical schools in the country, so even if we provide extra resources, we only have 170 medical schools, which graduate 18,000 medical students a year. I'm simplifying, but just to make that we are hundreds of thousands of healthcare providers short, and right now we only graduate 18,000 medical students a year. So in order to, I did some rough calculations, you would have to have every medical school in the country increase their medical school class by 30 right away, all of them, in order to kind of bring parity to the projections on adding all these individuals to the healthcare system. And it's just not possible. I talked to, for instance, Dr. Hedges, Jarris here, who runs our medical school, and he's working hard at different ideas, but he can only maybe do 5 or 7 more students because he just doesn't have the facilities for it. We would have to really invest, not just the grants, but we would have to have a national movement and probably a change in focus of what is going to define. This is what, again, worries physicians. A change in focus of what the definition of primary health care will be. Will it be care from a cohort team of nurse practitioners and physician assistants, of whom many are fantastic, or will that be the primary health care system? And the specialty system will be peopled completely by people who went through the long program of medical school and residency. Is that acceptable to America? I can tell you, when I was working in Kau at one point, I was one of the docs at the hospital in the ER, and the way we covered the ER, 'cause we covered it 24/7, right, was we had 3 of us. I did 1 week, then the next guy did 1 week, then the next person did 1 week, we just rotated. And when we were off of the ER, we ran the clinic, okay? Well, we went to the community, and we said, really sweet people, but a classic rural community. We said, you know, we couldn't just have Josh and another half-time doc on call. So anything bad happens, he'll race in, or she'll race in. Heart attack, stroke, big problems, major respiratory failure. But all the other, well, instead of having 3 full-time physicians, let's hire 5 additional providers, nurses and nurse practitioners, to handle the clinic, to handle some of the other teen care. The community rejected that out of hand. They really wanted those 3 physicians. And it was a big public meeting, and and I would not be surprised at all if, at least in the current mindset of the country, I'm not saying good or ill, I'm saying that it would be a major transition in thinking about healthcare. So these are questions that will continue to be a problem, but I do cite that as a major wild card in the system, because if we are too aggressive at moving to smaller Medicare reimbursements, a much broader Medicaid system, a lot of physicians could leave practice, and it would be a problem. Question, or you're signifying 5? Yeah. The concern that is expressed graphically is correct, which is a lot of physicians. We have a large number of physicians, for instance, in Hawaii that are 55 years or older that have been engaged in one healthcare system, and when large change happens, sometimes it sifts out, people move on, they retire, what have you. But if it's a very troubling situation where someone had a different expectation, they might quit altogether. And if that does happen, I think you're going to see probably major revisions of the Affordable Care Act. That's just one thought that I have. I also wanted to kind of reiterate this idea about population health and technology. It is possible, in spite of a little bit of skepticism on my part, it is possible that over the course of 5 or 10 years, 5 years ago we didn't have this, okay? An iPad that you could quickly get pretty decent, quick, I have a friend, actually probably our sponsors, wonderful gentleman, Alan Tice, right? He's an infectious disease specialist. I really love that guy. He, when I'm out in Kalu or Pahala or Kohala or whatever, and I see a patient that's got a bad infection, I'm sure I break a lot of rules, but take a picture of it on my iPhone or my iPad. I ask the patient, is it okay if I share your situation with a specialist? I text it to him. He sees it, or I email it to him. He sees it on the screen. He says, Josh, make sure you incise and drain that. Or, Josh, this is a X disease. You have to make sure you give these 2 antibiotics. Or, don't forget to culture that. Immediate consult occurred in real time. Didn't require a helicopter or a plane fixed-wing transport. Didn't require an admission. I saw them the next day, probably, or I kept them for observation. And that small amount of technology did create incredible savings in time and money for that individual. And so technology could provide some game-changing events. And I know that those of you guys who are young medical students, or nursing students here, you will have an iPad mini, like, for sure. And you will be able to get your MRI result from a month ago on that thing instantaneously. Wi-Fi system. Whereas a lot of colleagues that are the generation ahead of me, I will not say old farts, but they are definitely not, using technology all the time. They're a little bit more reluctant to go that direction, and they have much better diagnostic skills, and they have a much better grasp of kind of that interaction between people because they spent so many years spending time clinically and doing histories and physicals. But the system has moved away from that capacity allowance in the new era of healthcare. And that is a wild card. It could mean that we provide a lot more streamlined care and maybe we'll provide better care. I don't know. It's a good question. He didn't get paid. Very good question. Let me say what was said so that tell me what the question is as well.
You had a consult
Yes.
So free.
Yes.
So he,
Very good, excellent point. I agree completely. So the statement was, so I took a picture on my iPhone, sent it over to a head of infectious disease at a tertiary care hospital, and he didn't get paid anything. So why didn't Alan get paid anything? Well, one, because right now the insurance system hasn't caught up with these changes. I would say that is definitely an amendment that has to go into the Affordable Care Act.
I mean, why would he do it? I come over to my house, wire my house, and buy, you know?
So the question is also, so the larger question is, why would an individual participate in a system that wasn't in their own direct self-interest? And Alan has Alan, you know, he drives around an old beater and he doesn't care, right? But not everyone is like that, and also not everyone can afford to lose the work that they've trained for. So I believe wholeheartedly that as the revolution occurs with electronic health technology, that you will also have to see at the same time a structure for reimbursements. And that's another part of, if it's done well, if it's done properly, for health information exchanges. One of the reasons they're starting right out of the gate with secure messaging is because it be more trackable, therefore it should be billable, it should be accessible. HMSA tried in a small way when they did online care, which I was not a firm believer that was a good approach at first, because I still believe in exam. I'm a family practice trained person. I think you need to do it. You have to have some physical exam. But for the purposes of consultation and extra advice, to do a 5-minute visit and have some payment to that specialist on the other end of the line makes all the sense in the world. And it might be very good for the profession, because in this case, some people may not want the large overhead of a practice, or they might be in the phase of their career where they prefer to do consults from home. So there is some additional potential for technology to work. But we have to, as healthcare providers, be mindful that we don't just get ripped off in the process of healthcare change. In other words, for those who have gone through heavy-duty training and have something to offer, they should have a meaningful place at the table to discuss what's appropriate for their payment and so on. And that is one of the things I don't yet see in the Affordable Care Act. Though there is the potential for that, again, through some of these other models. For instance, and I'll take the next question in a second, if I was setting up an accountable care organization today, I would rely heavily on subspecialists that wanted to only provide a smaller amount of care in their lives but still wanted to be involved in healthcare, because it's an opportunity to both include the wisdom of those who have been much more experienced and also fit their lives in a new model which will have some shared savings. And so that's the kind of thing that smart people who drive these pilot programs, or whatever you call them, will do. I think I got a question.
Because the neighbor islands and
Okay, can you hear me out there, our islands and the other sites? We can have your questions ready. Just let us know who you are. Present your question.
this is Hilo. Can you hear us?
Yes, we can.
Yeah, we have several.
We can't see you,
One
but we can hear you.
Even better. On the state level, one issue that maybe senators could have some influence on is tort reform. We know from other states like Texas, where they've had tort reform, they've been able to attract physicians. That's an ongoing problem here. Even the state-employed physicians are not indemnified by the state. There's a private malpractice company that's fairly expensive. No tail insurance is provided, so it's a disincentive. One other just brief comment about the readmissions to the hospital. I think the law of unintended consequences is that because there's a financial incentive for hospitals not to readmit patients, what I'm seeing here in Hilo is a tendency for the ER docs not to admit patients who actually do require readmission because of the problems that the hospital then faces under the ACA. Thank you. And there's a few other questions.
Let me address those. Who is that over there?
Jason Morshell.
Hi. So yes, I've submitted the medical malpractice bill, I think 4 times. And I'm going to be frank, I have 26 to 28 attorneys at the Capitol and then me. So it's been a challenge. We passed it out of the Health Committee a couple times. Let me tell you one reason I think medical malpractice reform, or at least a revision, is important. One reason is that right now the current system doesn't allow for anybody with small injuries or small malpractice events to get anything. Under $250,000 of injury means that there are no attorneys that will take the case. And if I'm speaking as a left-winger socialist type, which is not totally who I am, but some days I am like that, you can't get anything for the working class. I mean, if you have, if I chop off the end of your finger, but it's not worth $250,000, no one's going to take your case, whether it was total malpractice or not. And so the system doesn't really fit the need. We have had very, very few cases that were large in our state, and those cases could be handled with a reinsurance pool, which some states have done, and we could go to probably a no-fault situation, which I still think actually would even be somewhat palatable to the attorneys in the state, because they could litigate a lot more smaller cases and it would be a little bit more fair. So I agree with you that there should be some malpractice reform. Also, I'm really concerned about the readmission bias that you mentioned, because if people end up gaming the system to just say, look, we're not going to admit you, but we'll see you again, people are going to get pretty bad care, and a lot of people are going to die because we didn't fully rule out their pulmonary embolism, or we didn't have them completely ready on their blood thinners, or any number of problems that we probably could handle in a basic way. I think hospitals are going to have to evolve, and I think that that's probably what we'll see. We'll see more, like the hospitals, if they have fewer admissions, are going to have to do something with their space. And I'm already hearing a lot of discussion about other wings and other services that will provide kind of intermediate care. Will it work or not? It seems like a bad shortcut to me, but that's the kind of fight that's going to go on in the next phase of the Affordable Care Act debate. We had another Hilo question, I think, before? Yeah. Go ahead, Hilo.
That person who just asked the question said there was another question? Or someone else in your team or in your group? Do you have another question, Hilo? Can you please state your name and your question? Okay, we're going to open to the other islands. You see, it's a requirement that they do ask questions in order to get CEUs. So we'll open the...
So the coordinator of the site, please make sure if you got anyone that really wants a CEU, they're welcome to attend, but if they want us to send a CEU, somebody needs to participate verbally. Please use the opportunity now, because we have very little time. Otherwise, we're going to go for anyone here at the Queens. But I know there's so many people on webinar and VTC sites right now.
Anyone else out there? Kauai? Maui? Big Island? Any more questions?
As they get ready, why don't we take another question here? You had
Good
a question?
idea.
Also, if your mics are muted by the state telehealth system, please call them and tell them to unmute you, because we can't tell. Nobody's saying anything. We know we got through to the Hilo, but we're not sure about the other side since no one's saying anything.
I had a few issues. When I lived over in Kailua Kona on the Big Island, the OBGYNs over there, this was a few years back, were just leaving the island in droves. And one of the things they complained about was the cost of insurance, and the other thing they complained about were having to deliver a baby to a patient that they had never met, and the cost of that care and being responsible on their insurance if anything went wrong. That's the first thing. Another is, have there been any changes to the insurance?
Let me address that. I'll
Okay.
just in one by one so I don't forget. Okay, so OBGYNs have been leaving because, yes, their malpractice is higher than almost any other malpractice, because they're a surgical discipline and a medical discipline, and they're a procedure discipline, so there tends to be some extra reimbursement. But it was disastrous. 1 or 2 bad cases, and they're going to happen. Knock on wood, they don't happen often, but there are cases where since you don't know your patient, you don't know that they had a larger baby or that their mom was doing drugs or that their kid just had a problem in prenatal, or they had no prenatal care is another problem. So a lot of them left. Now, the way we've been reversing that is actually we've been hiring physicians. Elite Health is founded now, and it's an affiliation with Kona Hospital, and Elite Health provides specialists, including, I believe, a few OBGYNs. And so this is a movement that we're seeing. It's another part of the bigger milieu of the Healthcare Act, the Affordable Health Care Act, which is we might see a lot more employed physicians and fewer private physicians that have independence. And I don't think that that's a great solution, but it is what could very well happen, and we're seeing here in Hawaii already. And then, of course,
So were there any changes to the insurance rates, or were there, with this legislation that's happened, have there been any changes to that insurance?
had their medical malpractice insurance been lower, it's very possible they would have stayed. But that takes a fairly long time to have an impact, and I'll be frank, it is unlikely in general that bill will pass in Hawaii, in general. I will tell you a little vignette, and that's that at the national level, when they were negotiating the Affordable Care Act, there was a deal on the table before it passed in 2010 in March, and the deal was this: let's come together and have agreement, a much larger majority, rather than just all the Democrats voting for it and none of the Republicans voted for it, just squeezing it through. The deal was the Republicans were going to float the amendment to have medical malpractice reform, and the Democrats were going to, who in general oppose it, were going to swallow hard and accept that in exchange for a much broader public option, which was that was the baby of the left part of the Democratic Party, to have a bigger public option.
Or expanding Medicare.
Right. And so, yeah, or Medicare for all. I don't want to get into that debate right now, but the point I'm trying to make is that both parties would have compromised, and we'd had some malpractice reform and a broader public option. And what I'm told is that it became clear to Republicans that it was simply the bill in general was too anathema to them because of the mandate and so on. So they didn't want to engage at that level and make that deal. So when they walked away from the deal, medical malpractice reform fell out of the bigger bill, and lots of other compromises were made, and this is what we got. But that was an opportunity probably to get medical malpractice reform, but it's not my place to say what a U.S. Senator should do. Do we have another question from the...
Gentleman over here has the mic.
Another question over here?
Yeah, do you know what a grand aid is?
A what?
Grand aid.
A grand aid?
Yeah.
I don't know that term.
It's something they started in the third world. It's been incorporated by primary care into the 1115I that's going to go in. The object there is a triage list of 30 questions and an iPad that the notion was anything, half of all office visits could be eliminated if you went to see a knowledgeable grandmother.
Oh, I get you.
This is just a list. It's like the community health workers, and the idea is to stop people from going to the doctor, and that's going to directly affect whether people retire, what's going to happen to the hospital rooms.
So you bring up a good point, and whatever it's called, whatever term one uses, conceptually, it's going to be very difficult for us to train a whole new expanded workforce of healthcare providers quickly, and it would be ideal to not just do a superficial fix to the healthcare system, because we're not going to come back to this for a while. So if we can muster up the courage to do a lot more preventive medicine and a lot more health literacy, it probably is a good solution, and I do think there should be some resources applied to that. So if a doctor or nurse hires that person in their office or in the community, they're paid for it, and then they can make a good, educated decision on when someone really needs to come in, because it's not a perfect system, and a lot of times there really is just nothing better than a quick physical exam, even if it's very short, from any healthcare provider that's been trained clinically. But I support something like that.
Anyone else have a question?
Valerie has one.
I always hear about increased costs because all these people will have, insurance and access to the medical care, but I think it's disingenuous to say it's only increases because there's no talk about the savings from people hopefully getting better care and staying out of the ER and staying out of the hospital. And because these people are receiving care anyway, they just keep going back and forth to the hospital, like those 50 people that are going to now be served by that new program that the state of Hawaii is piloting to take, do community visits for the frequent flyers that spend all their time in the ERs.
Let me address that concern, which is good. It's a good observation that, look, we do know that system-wide approaches to problems can move mountains. There are successes. It can happen. So the low-hanging fruit, okay, unnecessary emergency room visits. 20% of the healthcare system, 20% of HMSA's dollars are spent on that every year, over $400 million on unnecessary ER visits. That money could definitely be spent by them, and they agree, better on prevention and access to outpatient care and what have you. And it makes a lot of sense to do that. Also, long-term investment. I'm not overly concerned about spending more money on healthcare, provided we spend it right. So that we spend it intelligently, because there's a lot of things that we can do better. For instance, we can have fewer sick days at work. We can have more productivity, actually. You can have, we are in a relatively closed economy here, okay? So whether you spend 18 or 20 or 25% of your dollars on healthcare and healthcare workers, or you spend it on those in the, in the tourism industry, these are still jobs, okay? And so we just have to decide what we're going to prioritize. There are some fundamentals that you have to prioritize in a society, and that tends to be basic education, basic health care, and public safety questions, fire and police, okay? Beyond that, sky's the limit. You can decide. You can hire people and invest in roads, which are expensive, if people want them, or you can invest in hospitals and physicians and nurses if the people want them. It becomes an economic choice, but that money will tend to stay here. So I tend to think that even if we spend more, it's better spent on health and human services. A broader example might be spending money on early childhood education, okay? It turns out that if you actually want to spend money in any society, that's where you want to spend it, because you get a 7-to-1 return on your money. Everyone knows this. Far fewer people end up in prison. Many more people end up getting out of high school and not needing Medicaid or welfare assistance if you give them early education, which makes everything else easier to pay for, and it's just plain good for people because it's a good experience. It's good for the parents to be able to work and so on. But it's a paradigm shift because you don't see the immediate gains. And I think that same logic can be applied to putting in good systems of health care where people don't need to go to the hospital, they don't need to end up on 6 medications, they only need maybe 2 medications. They don't need to retire from work at 63 or 64 because they're incapacitated. We can use their experience until they're 68 because they want to work. So it becomes a fundamental question of how you prioritize your country's budget. It's an interesting question, probably, in fact, certainly far above my pay grade, but I would say in general, we should be spending more money on educating people so that they can become healthcare workers and become outreach individuals, and we should be spending a lot less money on end-stage renal disease, prison cells, and just clean up for severe drug and alcohol addiction problems that are very, very hard to treat. So I think we're going to probably have to wrap up this question, but if we really do decide as a society that we're going to prioritize these things, we're very likely, per your statement, to come out a lot better. But anyway, thank you for having me. I really appreciate it. I know we're at the end of our time, but anytime you want to get in touch with me, please call me directly. It's my pleasure to talk.
I'd like to thank everybody for being here. Hope you'll come back next month. Our topic next month will be HIV and AIDS. Thank you very much, Senator, Doctor. Excellent training and update on all that's going on now with the affordable health care.
Please remember next month we will have food starting at 11:30 and something we never have, which is actual validated parking for either the hospital or POB 1.
I'm going to give you my...
It doesn't work for POB 3. So the speaker is bringing some resources with her to make sure she's got a great audience and you can hear a really dynamic speech. Thank you. On HIV and AIDS.
I would have liked to. They wanted me to get into all of the years of the Affordable Care Act, and I could have probably gone faster. But absolutely, diet, exercise, absolutely. Those essentials would probably be much better than all the other pieces engaged. No soda, stuff like that. Stupid move. It's terrible. Because certain states have political... Terrible. I agree.
And why can't people die with dignity? I mean, we can euthanize animals. Why can't we let people
call it whatever you want, but call it reinvesting all this money in all your
good options?
And your health. It absolutely, especially of investment, unless you have no cap on expenditures, which is not real. So therefore, when people try this game about the death panel, that's just because they want to kill the whole thing. It would be much better to have a real discussion.
Yeah, and COPD, they have revolving doors. The last year of their life, a lot of those COPD patients are in and out of the hospital.
I'm willing to say it, and I probably will be saying it at some point. If you bring humor to it, like every patient I see in the ER, right, I talk to if they're older, I say like, if they're going to die soon, and they've got a big problem. I'm embracing her right at the edge, and I'm saying, you don't want to be intubated because it's terrible.
Yeah.
But she needs to understand.
No, but she needs to know. No, you need honesty. If the doctor's going to say you're going to be back 100%, that's not honesty.
It's not that. It's that a lot of people, in fact, most people I've come across at that point, I'm talking about someone who's got terrible metastatic disease or whatever, they don't even know that I could get them home for the last week rather than dying 2 weeks later at Queens.
And tubed up the whole time.
Oh, I agree. I believe it should be totally funded.
It's funded.
They need more money. We got to go do obesity. I'll give you my card though. I'm going to go though.
Is there a website for medical doctors that you can get information about them, in one place? Is there one like that?
A website for all the doctors in the state?
Like where you could find out about the doctors, like all the different doctors and get patient evaluations and
what was your name again?
Christian.
Thanks, Ed. Yes, there is. In fact, more and more, you can go to the Hawaii IPA website. You can go, or you could go to.
Out Hawaii IPA.
Yeah, if you Google it, it'll come right up.
Independent Physicians Association.
Which is where I am. Or you can go to. You can just go straight up to HMSA, and they have a lot of extra data.
So there's no place where because I've seen some private, ones where they evaluate doctors, but there's
Four reviews,
no good.